Hello everyone, welcome to today's lesson with Caleb Mulonga. Today we are going to look at the nursing care plan for asphyxia. In our previous videos, we have looked at the pathophysiology for asphyxia. Therefore, it is only right that we look at the nursing care plan. Okay, so as we know, asphyxia has to do with the infant or the newborn baby failing or having difficulties in breathing. So this can be due to several factors like you have seen in the pathophysiology. So make sure that check out the pathophysiology video of asphyxia if you've not yet checked it out. Let us go into details and find the problems that we can nurse in a baby with neonatal asphyxia. Firstly, we said the infant is having difficulties with breathing. Therefore, you find that the problem that we have firstly is ineffective breathing pattern. Why? Because they're having difficulties in breathing. So that can be apnea, that can be dyspnea, and the like. Okay, so our problem is ineffective breathing pattern. Let's go to the diagnosis. The diagnosis is ineffective breathing pattern due to an inadequate intake of oxygen by the baby, secondary to blockage of the airway in aspiration of meconium, blood, mucus or mucosius, or liquor. Or it can also be due to immature or weak lungs, evidenced by nasoflaring, cyanosis. You can also put others such as apnea, episodes of apnea. So our diagnosis here is simply saying that this ineffective breathing pattern is as a result of the baby not having enough oxygen intake, okay, due to the blockage that is in the airway. This blockage can be due to the meconium that the baby might have aspirated, the blood, the mucus, or the liquor. Or it can be as a result of the immature lungs in a case of prematurity. And the evidence are there to see. They can be apnea, they can be nasoflaring, they can be cyanosis as some of the evidence for this particular infant. We move to the goal. Remember, our goal needs to be smart. Our goal needs to be smart. The goal is to promote a normal breathing pattern within, we can say, 10 to 30 minutes of our nursing interventions. The reason why I have put 10 to 30 is because this is an episode of asphyxia, meaning the baby is not able to breathe properly. Therefore, we want to do it in the shortest period of time. Therefore, we can say 10 to 30 minutes of our nursing interventions. So that goal is smart. We move to our nursing interventions. Our nursing interventions are as follows. Number one, I will receive the baby in a warm, dry towel. Dry it immediately and completely from the head to toe to provide sufficient stimulation of the baby. So remember, immediately when we deliver on the mother's abdomen, we wipe the baby and then we wrap the baby in a dry towel. So that helps in the stimulation of breathing or breaths. Number two, I'll transfer the baby to a preheated resuscitator, laying in supine position with the head slightly lower and tilted to one side to allow for free flow of any secretions. Number three, I will clear airway using a penguin sucker to promote the patency or a clear airway. So we want to ensure that we suction this airway so that we can have a patent airway. Number four rather, I will stimulate gently the back and the foot by flickering the feet to initiate breathing. So if the baby is still not breathing by this time, we want to initiate, we'll gently flick, okay, more like rub the feet and the back of the infant to stimulate or initiate breathing. Then the last one we can also put, although it is a point that we are also going to put on our next problem, is I will administer oxygen at the rate of 1 liter per minute to improve tissue oxygen perfusion. Okay, after that, now we are going to evaluate. Our evaluation is that the baby's breathing pattern has been improved within 10 to 30 minutes of our nursing intervention, evidenced by, and you can say, absence of nasoflaring, absence of cyanosis. You can choose any, absence of apnea. All those are evidences that the problem that we had has been resolved. We quickly move to the next problem. So what is happening in our condition here is that in as much as there's a problem in breathing, there is also a problem in gaseous exchange. That is why sometimes these two problems, you can just choose one, in the sense if you do not know the interventions to put, but they are quite different. And the reason is simple. Impaired gaseous exchange has to do with the flow of oxygen into the body and the flow of carbon dioxide out of the body. Therefore, you find that because of the blockage in the airway, because of that aspiration of meconium, because of maybe immature lungs or respiratory compromise, you find that the baby will not be able to facilitate gaseous exchange. That is the best explanation that I can give. Then we move to the nursing diagnosis. The nursing diagnosis is impaired gaseous exchange due to newborns' inability to maintain adequate oxygenation and carbon dioxide removal, secondary to respiratory compromise. This respiratory compromise can be as a result of blockage of the airway because of the aspiration of the meconium, the blood, or any of those things that I had mentioned. Then evidenced by cyanosis. Okay, it can be evidenced by cyanosis or low oxygen saturations in the blood. Those can be evidences that there is reduced oxygen in the body. That means that gaseous exchange is poor. From there, we move to our goal. What is our goal? Our goal is to promote gaseous exchange within 30 minutes of our nursing interventions. So that goal is SMART. Again, even here we can say 10 to 30 minutes. Then from there, we go and look at our nursing interventions. Our nursing interventions are as follows. Number one, remember there's something blocking the airway. So number one, we can say, I will suction the airway to remove secretions to maintain a patent airway. Number two, I will avoid using fingers to clear secretions as they may be pushed further in the airway. So you find that sometimes the baby might have some visible secretions on the nose, and you might think that in the nose or in the mouth, and you might think that maybe I can remove with my fingers, it is much easier. But what you might not know is that by using your fingers, it might further push those secretions. Number three, I will assess oxygen saturations using a pulse oximeter to note and monitor the blood gases or the oxygen saturations as we usually put it. Number four, I will give supplemental oxygen to improve oxygenation and improve tissue perfusion. Okay, number 5, I will position the infant in a way that promotes lung expansion, such as slightly elevated position to promote lung expansion and ventilation. So those are our goals that we can put on this problem. Then we quickly move to evaluation. Our evaluation is that gaseous exchange has been improved within 10 to 30 minutes of our nursing interventions, evidenced by absence of cyanosis. Just like that, we are done with our 2 problems. We quickly move to our third problem. Our third problem is altered thermoregulation, which is hypothermia. So you find that because this child is not able to facilitate breathing, and something that we have to also consider is that sometimes in some scenarios, this infant will be a premature, which means that the regulatory center in the body, the heat regulatory center, and the tissue, the fats, have not been fully developed. Therefore, they will have hypothermia. Okay, so that is where the hypothermia is coming from, due to the underdeveloped or immature heat regulatory center and the absence of fat. So altered thermoregulation, hypothermia in brackets, due to not well developed heat regulatory center and inadequate adipose tissue, evidenced by low body temperature of 35.5 degrees Celsius. So you can put as you wish there. We move to our goal. What is our goal? Our goal is to promote a normal body temperature within 1 hour of my nursing intervention. Remember, hypothermia is very dangerous. So we want to make sure that within an hour of our nursing intervention, our baby is warm. Okay, let's look at our nursing interventions. Our nursing interventions, number 1, I will nurse the baby in an incubator to keep the baby warm. Number 2, I will cover the baby with adequate linen to promote warmth. So we are just putting in interventions that will keep our baby warm. Number 3, I'll switch on the heater to improve or increase and maintain the normal room temperature between 20 to 24 degrees Celsius for adequate warmth. So we want to ensure that the room is warm, so we are going to switch on the heater. If we have been to NICU, we understand that that ward or environment is very warm. Number 4, I will immediately change soiled linen and wet linen and baby clothes to prevent chilling of the baby. So we have to make sure that we change the nappies of the baby, the linen if it is soiled or wet, so that we prevent the baby from being chilled or cold. Then lastly, I will give the baby to the mother and assist to put the baby's skin to be in contact with the mother's skin for warmth, skin to skin between the baby and the mother. So remember that kangaroo care is very important. So when we put when the mother and the baby's skin are in contact, that means that the mother can actually help with the warmth to warm the baby. Then quickly we go to our evaluation. Our evaluation is the normal body temperature of the baby achieved within 1 hour of my nursing intervention. evidenced by temperature of 36.5 degrees Celsius. So just like that, we have maintained a normal body temperature for our child. So those are three good problems that we have listed and spoken about in details. So now let's look at risks. What are the risks that can occur, potential problems that can occur in our condition? Okay, firstly, we have to talk about nutrition. So you find that because of the poor or weak sucking reflexes, sucking and swallowing reflexes, this child will have a risk of imbalanced nutrition, less than body requirement. So you find that our first problem under risks is risk for imbalanced nutrition, less than body requirements. Then on the nursing diagnosis, risk for imbalanced nutrition, less than body requirements due to weak sucking and swallowing reflexes. So these sucking and swallowing reflexes are weak or poor. Then we move to our goal. Our goal is to promote an adequate nutritional status throughout hospitalization of our nursing intervention. So basically what we are saying here is we want to promote a nutritional status throughout hospitalization while we perform our nursing interventions, or while we put in place our nursing interventions. Let's look at the interventions now. How can we achieve this that we want to do? Number one, I will assess the baby's ability to suck and determine appropriate feeding methods. So that is the first thing that you do. You have to assess if the baby is able to suck and swallow. Number two, I will pass a nasogastric tube if the baby is unable to suck and swallow, to provide an alternative way of feeding. You have to insert an NGT. I will do daily blood sugar checking to maintain and prevent hypoglycemia. So we have to make sure that we check the blood sugar daily so that we can actually prevent and monitor also if there is hypoglycemia. Then lastly, I'll give expressed breast milk by nasogastric tube to meet the baby's nutritional status and prevent malnutrition. So basically that is what we can do. Of course, we can also talk about giving fluids such as 5% dextrose, and we usually give about 5 ml per kg body weight just for energy, or to improve and prevent, rather to prevent hypoglycemia, to improve the nutritional status and prevent hypoglycemia. Then we evaluate the patient, the baby. The baby's nutritional status promoted or improved throughout hospitalization, evidenced by weight gain. So that you find that the baby will now gain some weight. Number 5, I believe, we moved on number 5. So you find that in this infant who is having such a condition, which is neonatal asphyxia, they are prone to infection. Not only that, but you find that babies or infants who are premature and babies in general have a risk of infection because their immunity is not yet mature and fully developed. So risk of infection or for infection is one of the problems that can be consistently found in the nursing care for our babies or infants. So let's move to our nursing diagnosis, risk for infection related to an immature immune system. Like we said, our goal to prevent infection throughout hospitalization, to prevent infection throughout hospitalization of nursing interventions. So we want to prevent infection. Let's look at our goal, our interventions now. I wash hands before and after attending to the baby to prevent infection. So remember, when we're in NICU, we always wash hands when we're entering the ward. Number 2, I will not allow people or staff with respiratory tract infection to enter the nursery unit to prevent transmission of respiratory tract infections to the baby. Number 3, I will regularly clean the incubator to remove dirt which harbors pathogenic microbes. Number 4, I will administer prescribed antibiotics to prevent infections from being established in cases of contamination and successful entry of microorganisms in the baby's body. So basically, the last point is just saying I will administer prophylactic antibiotics to prevent infection, if that is the case. Or you can just say I will administer prescribed antibiotics to prevent infections, just in case the baby is exposed and has acquired is about to acquire infection. So it is more of prophylactic. Then we move to our intervention, our evaluation lastly. The baby is free from infection throughout hospitalization, evidenced by the temperature of 36.5 degrees Celsius. So that is our last, that is the evaluation, the last part of this problem. Then today we have a bonus problem, and the bonus problem that we have put here is risk for fluid volume deficit. Where is this fluid volume deficit coming from? It is coming from the fact that the child is not able to take anything through the mouth. So the child is not able to suck or swallow the milk that is given to them. So it is as a result of the poor sucking and swallowing reflexes, meaning that the child cannot take in anything that they are given to eat, to drink rather. Okay, we know that at this time they are only allowed to have milk. So that is our problem, risk for fluid volume deficit. Our nursing diagnosis, risk for fluid volume deficit, risk for fluid volume deficit due to weak sucking and swallowing reflexes. Our goal, what is our goal? Our goal is to promote an adequate fluid volume throughout hospitalization of nursing intervention. So we want to promote adequate fluid volume. Then we move to our interventions. I will pass a nasogastric tube if the baby is unable to suck and swallow to provide expressed breast milk by nasogastric to promote fluid volume. Number 2, I will encourage the mother to breastfeed the baby to prevent fluid volume deficit. Number 3, I will give normal saline 5 ml per kg body weight to promote fluid volume. Number 4, I will give dextrose 5 ml per kg body weight to promote fluid volume. So those are the points on evaluation that we can put. Then we lastly go to our evaluation. Our evaluation is the baby's fluid volume promoted throughout hospitalization, evidenced by absence of poor skin target. Okay, so there we have to say absence of poor skin target or a good skin target. Okay, so we want to ensure that the child has a good skin target. Okay, so that is the end of our lesson today. So if for any questions, you can ask in the comment section. I urge you to subscribe. To comment and like the video. You should also share the video to some people that may not be on this channel. Thank you for everything. Thank you for watching. Thank you for your support. God bless you. See you next time.